Good afternoon. Welcome to PGTME's second annual lunchtime lecture series entitled Critical Discussions, Multi-Stakeholder Perspectives on the Ethics of Pediatric Gene Therapy Research. Today is the third day of our series, and we will be talking about the many facets of hope as it relates to gene therapy in children. My name is Moshe Cohn, and I am a member of PGTME at NYU Langone's Division of Medical Ethics. Annually, the PGTME hosts a series of multi-stakeholder discussions on current topics related to the ethics of pediatric gene therapy research. It's a project of the Division of Medical Ethics at NYU Grossman School of Medicine, and you can learn more about it on our webpage in the chat. You can also sign up for our quarterly newsletter and to stay on top of what we're working on. If you're unable to attend any of the events in our discussion this week, we'll be posting captioned recordings on YouTube once the week has concluded, and we'll share the link with all of the attendees as well. You can check out last year's talks by looking for PGTME on YouTube. Today, we will feature brief introductions by our panelists about their backgrounds and their role here today, followed by a discussion, moderated discussion, and we are going to allow for audience Q&A as well. So please, throughout the panel, please submit your questions through the Q&A feature in the chat on your Zoom. And that's pretty much it. We're gonna get started and let everybody introduce themselves. I'm gonna go in order of my on my screen. So I'll start with Laura Palmer. Sorry, Laura, you're muted.
Hello, I'm Laura Palmer. I am a staff chaplain at the Children's Hospital of Philadelphia. I cover oncology and the special delivery unit, which is high-risk OB. I also do some work with the gender clinic. I've been here for 9 years, and prior to chaplaincy, I worked in journalism as a television news producer, and I'm also an author, and more recently an Episcopal priest. Delighted to be here today. Thank you.
Thank you, Laura. Jennifer?
Hi, thanks for having me. I'm Jennifer Siedman. I am the mom of a child with a rare disease called Sanfilippo syndrome. I'm also the president of the Sanfilippo Research Foundation, a small foundation that was formed over 20 years ago, primarily to fund research. The largest funding project we had is now in a clinical trial in 3 countries. It is a gene therapy clinical trial. And that began a few years after my son passed away. Currently, I am the director of engagement at Courageous Parents Network, which is an online web resource for parents caring for children with life-limiting illnesses. And the resource addresses the psychosocial and emotional components of caring for a child with a life-limiting illness. And 2 years ago, we developed an extensive unit addressing those emotional considerations for families who are considering or have participated in a clinical trial.
Thank you, Jennifer. Rafael?
Thanks, Moshe. Hi, everyone. My name is Rafael Escandon, talking to you from Bainbridge Island, Washington this morning. I'm currently a consultant, but have a long background in clinical research and development on the industry side. I've been working for the past 10 years or so in rare conditions and gene therapy. My original training is as a scientist in cardiovascular medicine, and then went on to do public health and medical ethics. But really, I'm here today and I'm a member of the PGTME because I'm very interested in this nexus between these very advanced therapies and their impacts on families, caregivers, patients themselves. So happy to be here today.
Tartania.
Hello, everybody. My name is Tartania Brown. I am a senior palliative care physician with MJHS, Hospice and Palliative Care Program in New York. I am a big palliative care advocate, but I'm also a very big sickle cell advocate and motivational speaker in the world of sickle cell, specifically because not only am I a caretaker for family members with sickle cell disease, but I also am a patient with sickle cell disease. So my unique story is that I'm a physician and a patient, and I come with a genetic disorder, a rare genetic disorder, but unfortunately one of the most common of the rare genetic disorders. So I have a unique perspective that I hope will bring some input to the group.
Thank you, and thanks for being here. Again, I'm Moshe Cohn. I'm a pediatric palliative care doctor and a pediatric intensive care doctor and a clinical ethicist in the PGTME group at NYU, Lango Medical Ethics. So thank you all for being here. Thank you everybody for joining, all the attendees. I sort of want to throw out a bit of a disclaimer, more of a just a level setting, in that I think, unlike the conversations we've heard this week and as well as last year, I think this discussion is a little bit more sensitive. It's easy for us, I think, to get lost in the science and use it as a bit of a shield. I can speak personally as a doctor, having been trained perhaps sometimes, unfortunately, to do that. It's easy to hide behind the science. But fundamentally, I think where we all come from and are here in this state of technology is a hope for the best outcomes in each of the situations where we launch from to sort of get here, in whatever perspective and training and background and experience. So because of that, it really gets to the core of who we are as individuals and as a community, a global community. And so for many of us listening, and even for us on this panel, I think these are really sensitive issues. And I think we're all fortunate to be able to come together and do this. And I've certainly appreciated a lot of the preparation that we've done to put this together. So thank you all for being here and being open to talking about some really sensitive things. I actually want to start with something that is a little bit perhaps unexpected. Is I actually wanted to address the issue of hope as a maybe counterpoint or in relation to faith. And I wanted to ask Laura, from the perspective of a chaplain, and in particular, someone who's been in the sort of the media, exposed to the media industry and how that plays off it, but where you've seen that those sort of play off each other, and also what that then means to you, and what you've seen hope and faith mean to your patients and the people you've been serving. And then I'll open it up.
Thank you, Moshe. Hope is at the heart of faith, and it is alive in the human heart, and never more so than when a child is critically ill. From the moment of diagnosis, hope is unleashed, because in oncology, there's always something to do. There's treatment. Everybody jumps aboard the hope train, and the T-shirts appear. We're warriors. We're fighters. There's an army of the child's supporters, and hope is just racing out the gate. We're going to beat it. And then over time, you see how hope shifts. How, with a relapse that then will sometimes require a transplant, hope is still alive, but it's sometimes more muted, but it never dies. And one of the things I have done in the oncology world with transplant, children get transplants for sickle cell disease with Crispr therapies now, and for the leukemias, and bone marrow transplants and CAR T therapy. So I offer a transplant blessing before the cells are infused, because this is a moment of just profound hope and faith that I think transcends religious boundaries. I will offer families a blessing before the cells are infused. I start, and by and large, our hospital is a largely Christian population. I have done blessings with Muslims and with a few Jewish families, but primarily Christian. So I start with Psalm 121 because it is one of the most beautiful Psalms in the Old Testament, and it's between 2,000 and 3,000 years old, and it's a Psalm of hope. And for me, it's like, this is the hope that has burned in the human heart since history began. I lift up my eyes to the hills, from whence cometh my hope. My hope comes from the Lord. So I read that first, and then I offer a prayer. And I always will make a point to the families in talking about a blessing that our hospital can do anything that can be done for children in the world. And yet these cells are a gift of creation, whether you call it the universe or whether you name it as God. We cannot make these cells in a laboratory. They have to be given. And that for me is deeply, deeply sacred. So in the prayer, we thank, if it's an unrelated donor, I pray that God's blessing be on the donor who gave of his or her very essence to help heal a stranger, and ask that we be inspired by that generosity. With CART therapy, with a CART transfusion, and with CRISPR, we give thanks for the technology that has been given to help create breakthroughs in treatment. And then I pray specifically for the family, and at the end, if appropriate, use the Lord's Prayer, which, brings everyone together in this moment. Physicians who know it will jump in and pray, the nurses will pray, the parents pray. And I think it's a place where hope really shines in a powerful way, and it's honest and genuine, and brings us all together in a moment that is, for me and for I think everyone else, deeply sacred, without tripping over religiosity.
Thank you, Laura. That's really it's sort of what I wanted to hear, and we've talked about this before, and I certainly don't want people to be uncomfortable. We've talked before about how religion can often make people uncomfortable, and what I think you've seen, and I've certainly seen, is how that there's a way to drive through the specter of religion and get down to what people are truly hoping for, what they believe, and what they have faith in. Jennifer, I'm curious to hear that that the reaction to that from a parent.
So I think, and I certainly hear this from a lot of the parents that I interface with at Courageous Parents Network, but personally, I think of hope as something that's very fluid. And I like to think of hope also as an opportunity. So it brings an opportunity for greatness and good, which also sort of bolsters our humanity, right? And is part of our faith. It can be an opportunity sometimes for disappointment, and we have to be ready for that. And again, sometimes faith can help us refine or redefine our hope. And I think as we travel at Courageous Parents Network with the families that we're traveling with who are caring for these children, what we try to do is encourage them to think of hope as fluid, and to think of it as an opportunity to find, refine, and redefine again along the path. And I know personally, like a great example of this that I can give from a parent perspective is to say, when the research that we were funding into clinical trials, gene therapy for Sanfilippo syndrome, sort of came to bear, my son had already progressed way beyond probably the expectation that he would be able to participate in that trial. And I would say that really challenged me as a parent to understand that I could still very, 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 very much hope, even for my own child, even though I saw the limitations of what science was not going to be bringing him. And, as a funder, I had to keep persevering, right? We needed to bring this project forward. And as a parent, I needed to be able to celebrate the hopes of other parents and see them as part of mine around the research. And it's really funny as a bereaved mom too, like one might say your hope disappears when your child dies, but the reality of that is not true. It really, in some ways, can present itself so differently and so strongly. And that's why I always come back to that hope is so very fluid. You can really feel it in any situation. And I think when the tension happens is when we think of it as a stagnant thing, or give it one assignment like a cure, right? We can't give it one definition.
Yeah, thank you for sharing that. I very much appreciate, and I've heard this many times from parents, where the hope that fluctuated, as you mentioned, the fact that it's fluid, that it's not just fluid, it also incorporated different components of your experience. There was the hope about your child, and there was the hope for the success of the project, which then affected other children. And I suspect, and I just having met you briefly, but that it then provides this, it's a reward, a bit of a reward and a legacy of what you accomplished, and what your child accomplished in the process. Is that right?
Yeah, and it's a way of being, for me, and certainly, obviously, since I'm choosing to do the work I do, it is a way for me to continue my bond with my child, right? And keeping that perspective helps you to maintain the hope, or helps me to maintain hope.
I'm going to try to use some segues here, because I didn't necessarily think Laura was going to bring up CRISPR, but I want us to jump on that over to Rafael. I remember when as a self-described science geek, I was reading about CRISPR, and it was knowing enough, having been trained in medicine, knowing enough about genetics, it was extremely exciting, in a way that I think those of us in the field, felt the same way, that this is then the frontier, right? This is the next step in the frontier after the Human Genome Project, after everything since, and this is what's going to lead to the next stage. COVID notwithstanding, and the vaccine, mRNA vaccines, but CRISPR is really the idea to pull it up on a screen and literally edit like a word processor in theory. And I wonder if that's the kind of hope that brought to industry, as opposed to sort of just, I think, the perhaps cynical view that many take about the hopes of what industry is trying to accomplish. You and I both know, we all do here, having interacted and working with people who have started companies, programs, nonprofits, including biotech, started by parents because of their children or family members. So I'm curious as to your experience and hope with things like CRISPR.
Yeah, no, thank you. And thanks to Laura and to Jennifer for your comments and reflections. It's there are a million things I'd like to pick up on there, but to the question, Moshe, I think the as you say, this new frontier is so exciting. It's difficult to restrain, I think, the enthusiasm amongst scientists and in the industry, and also clinicians and investigators who've been introduced to the possibility of having gene replacement or gene editing in patients that didn't have treatment opportunity, that typically didn't have treatment opportunities in the past, not to mention potential curative opportunities. So from the industry perspective, it's just enormously exciting. I think certainly you've heard me say in the past, and others who are close to me, I think this is, in terms of hope, this is an opportunity to really remake, I think, industry's relationship with patients, caregivers, investigators, and certainly payers. To quote an old ad, this is not our father's biotech industry. While we've certainly gotten here on the backs of many scientists, I don't think the old model of sort of pharma development and marketing really fits here. Things are going too quickly. There are too many patients that are in need that have hope. And so I think what myself and others are trying to do is to really harness and channel the best possible product candidates and to get them into the patients that potentially could benefit from them as quickly as possible. That involves cooperation. That involves not just amongst regulators and others, but also increasingly with companies and patient advocacy groups and other partners. And that's the future. So I have great hope for that. I think traditionally, just final thing I'll say here is that traditionally what happened is that there was something hopeful, something that generated hope, a scientific signal that came out of the lab, and then you would essentially transfect that, pun intended, enthusiasm into sort of translational investigators and then into clinicians. But every step of the way, there was this process of generating sort of scientific applications, clinical applications of what's happening here. I think this new frontier is so broad and so exciting that we've got real gigantic reservoir of hope here, and I think we need to be responsible about distributing that.
Thank you, Rafael. As I sort of thought about how to frame this and being careful about, knowing that this is sensitive. Those of us in palliative care, Tartania, knows as well, that we, as Laura mentioned, we talk about hope as being fluid, and Jen, that hope is fluid and it can change with the course of disease, and that we do hope for different things, patients, families, and all the stakeholders as we're talking. We hope for different things at different points, depending on our mood, depending on what's going on. As I was preparing, Rafael, you mentioned something very poignant. I didn't want to define hope and take out a dictionary and say, hey, well, what is hope? But as it relates to what we're talking about, Rafael, you mentioned how this is now something that's possible. These things that we can accomplish, whether it's today or in 10 years or 20 years from now, they're real. And that hope, and I got this sense certainly from Jennifer, and I've gotten this sense from the many families that I've taken care of. Hope is always, or almost always, about something reasonable and possible. It may not be possible today, and it may not be possible for this child, this specific family, but it's possible. And that's where the sort of that blessing of science comes in. What we can do, we're discovering what we can do, is what's possible and providing the hope for that. And the flip side, unfortunately, right, is then that, we are a little impatient as human beings, and we want those things now. And I wonder how this then relates to what we are about in PGTME, right? This is about ethics. So how does that work? Where I see a tension from an ethics side, and I want to bring that in, is that we are in a very, I'm going to say, American fashion, so perhaps uniquely, the refrain is autonomy. It's the prized, the prime directive, so to speak, of medical ethics in the United States. So the autonomy of a patient, what we want, what we choose for ourselves or choose not to have for ourselves, is takes pride of place. And I wonder how that balances then with the idea of hope. In I'm hoping for something and I want that thing. I want to sort of leave that open to any of you to react to that.
A mantra I use, more really related to try and motivate teams within a company, is truly, I mean, there's nothing hokey about this, but patients are waiting, to your point, Moshe. All it takes is talking to parents, patients themselves, advocates. And traditionally, industry has been, at least in clinical research and development, quite separated from the identities of the patients that you're serving. But in rare conditions and genetic conditions, that's a little bit different. So that to me, and to the teams that I try to motivate myself, is that hope and that ethos really, it matters. I never try to forget it. These things can take a long time, but we also try to dissect out the things that are just sort of historical legacy, get rid of them and move things forward. And to pick up on something Jennifer said, and you mentioned it as well, I just want to emphasize this, that the contributions of patients and families do not end when they finish a clinical trial, or they do not end when the patient's no longer with us. I think it's up to us as responsible stewards of the sacrifices and the burdens that patients and families have made to advance the science and to keep that flame burning. So I really want our industry to continue to do that and to expand that.
Hey, I actually wanted to jump in on a couple of things. I think I love, Moshe, that you brought in palliative care, and I love that you and Jennifer, I love how you talked about how hope changes and it's fluid. So I hear you, Rafael, when you're saying that the industry is looking for the future and doing the next thing, and you give honor to those who've given their sacrifice. But I don't know if that's like they in that sacrifice had hope, and they had different types of hope. And part of what I do when I do palliative care is help people to readjust that hope. Like, instead of hoping for a cure that may not be there now, but you might be hoping for a good day, or you might be hoping for a good death. You might be hoping your hope can change. It doesn't always have to be this, we're going to get everything right. And in terms of autonomy, we always, yes, our I love what you said, it's our prime directive that we are always autonomous, and it's always what I want and what I need. But the reality is we live in a collective. If this COVID-19 has not taught us anything, is that no one is an island, and we all get affected by things as grandiose as infections and diseases, but as simple as like feelings. We are all affecting each other. And so this idea of like, I'm independent, I'm individual, but we know that we need to think about hope in different lights and in different ways. And it doesn't always have to be like to win, or whatever your definition of winning is as an individual. Your definition can be comfort. That could be hopeful for a group, a collective. And then I'm going to stop in a minute. But from a sickle cell perspective, we haven't had any options or availability. Although sickle cell disease was the very first genetically described disease, and it was first put into science books over 100 years ago. Like, we are now, like in 2021, now starting to come up with FDA-approved meds and treatments that we can use for patients. But now, like, it's so late. So all that time, persons with sickle cell disease had to redefine hope. Hope wasn't to be treated and cured. Hope was to have a good day. Hope was to be believed. So hope doesn't have to always be this perfection of this is what you're going to achieve as greatness. Greatness can be a very simple thing. And I think redefining hope sometimes is always important too.
Please,
I
Jen.
think too that you're hearing, or at least I'm hearing out there in the ethos of families and patients willing to address hope in that way. Because when we think about how families will report now on outcomes from trials that they're looking for, what do they value in the outcome of a treatment? So it may not be what the researcher has put forward. It could be something more simple. Like, I would just like my son to be able to sit cross-legged on the floor for the rest of his life. And so these patient-recorded outcomes and the embracing of that by industry, and I have to say, I think is an example of how patients and families have the capacity to adjust. And I think of hope again like an opportunity, because I think it's an opportunity to see what is possible, but it's also an opportunity to see what is impossible. And the reality of it is that there are a lot of things in our lives that are never going to be possible, that are always going to be impossible. And you can still hope around some of those impossibilities. That's about expectation, which is a completely different thing from hope.
Yeah, Jennifer, I love how you framed that, and I, in particular with what Tartania was just saying, when we think about the idea of what's possible, and so that's the excitement in industry. What I've learned, certainly with my participation in PGTME, and then I think even more so now with the pandemic and the technologies that we've been leveraging, is that we may have these amazing technologies to leverage, and we can pour all this money into it, and it may not matter in the end. It may give us something. We might be hopeful that a vaccine is a cure, or that it will really be preventive. We might be hopeful that whatever pill is coming out is also going to be effective in the way that we want it to be. We might be hopeful that CRISPR or gene therapy in other forms are going to be curative, or that it will enable the small victories, the small points of relief or comfort for a patient. At the same time, I think I've certainly experienced both in my own communities, but also from knowing and taking care of patients in other communities that share a common disease or a common mindset, whether it's sickle cell or in my community, which would be the Ashkenazic Jewish panel of diseases, that also may coincide with, I'm going to say I'm not going to say education, because that's in some ways subjective in terms of where it comes from, but a lack of knowledge. So any community that is disproportionately affected by not having the information. I probably mentioned this to several of you, but I've had patients in the context of palliative care who've asked, for a patient who's brain dead, can they get a brain transplant, right? Because it's in their minds, it's possible, even though we don't have that technology, but they've asked for it. And patients ask for other things that for their one patient might not be possible, but that for other patients might actually be possible. They've heard about it, they come to the hospital asking for it. And so now this information is out there. So I kind of want to throw it back to Tartania, in particular with sickle cell, right? You mentioned how it's the most common. It was the first discovered. And I certainly, as those of us in medicine know, it seems so simple on the surface. It's a single nucleotide. So what does that mean with respect to hope? What you as a patient, as a doctor, and then as an advocate from a community standpoint, what is the hope with gene therapy, and how do you think about that?
I love that you said that. Thank you. So as much as people know about sickle cells being such a simple genetic change, or as much as people are aware that it is one of the most common of the rare disorders, is as much as people don't know at the same time about the day-to-day of the patient and the lack of treatment and lack of options that existed for decades up until now. And so I'm always coming from the angle of hope is different, because we haven't had that option. And now we do. I literally get emails daily from friends and colleagues too, saying, hey, there's this new CRISPR, there's this new genetic therapy, you should get it. And I'm like, it's in research, guys. It's not here yet. Like, I'm still living the day to day. That's the future. That's the hope. That's for the next generation of persons with sickle cell. And I'm super excited and happy about that. But that's not all the folks that exist right now. Right now, there's shortage, there's lack of knowledge, and we're not at the table. We are always at the back of any ideas, lines, thought processes. We're now at the table. Like we had a conversation more recently where people were talking about like industry was talking to muscular dystrophy and all these treatments and all these other genetic diseases have all these treatments. And I was like, wait, industry talks to patients all the time? This is a commonality? I had no idea, because up until this year, industry didn't come talk to anybody with sickle cell. We weren't even we weren't in the room. We weren't at the table. We didn't exist. So now we do. Now we are. And I'm super happy. And yes, there's a lot of hope for that. But again, that hope is for the future. That hope is for the next gen to be in a completely different place of where we are now. But all the people that exist here and now today, their hope is very different. Their understanding of their day-to-day disease is very different. Sidebar, I went to doing an advocacy to some government people about sickle cell, and one of the Congress people said, "Isn't that disease cured? Like, why are we still talking about it?" So, like, there's just not a lot of awareness of this disease. Not only are people not aware, we were not at the table. And so when you said needing to distribute out equally, I feel like we're finally at a place where that's starting to happen. So that gives me hope, but my hope is also muted. I don't have this existential hope of this, oh yay, I have like okay, let's relax kind of hope, because that's just how it's been.
Jennifer, I'm curious, and again, because I think I've seen both sides, that sentiment that Tartania was just talking about from herself, and I think from the sickle cell community, that's, to me, sounds so similar to, I think, what parents of children with rare diseases and also go through, because when there's the large community, let's say in sickle cell, which is a much larger community, but San Filippo, right? I don't know what the size of that community is. And in the same vein, you then have to wait and wait for what? Wait for industry to catch up and to figure that out, when from a financial standpoint, it's not necessarily so viable.
Yeah, I mean, obviously, my son was diagnosed 20 years ago, so science was very different back then, and we were looking at very basic science in the beginning. But I would start with that anybody who gets a diagnosis immediately gets put in a state of urgency, right? You are always living in a state of urgency when you or your child has something that is going to be terminal. You can't escape it. That urgency has caused a lot of people to withdraw and feel defeated, and one could interpret that as a lack of hope. It certainly mobilized my husband and I to take action, to drive research. Truthfully, sometimes it may be the detriment of my family, because we were so hyper-focused on that for the longest time, until my son's medical issues became so complex. But it continues in rare disease with research, I think, because there are limited patient populations, and for a lot of rare diseases, that creates an urgency within industry as possible therapies come on board and everybody's competing for the same small population of people, and that creates a weird dynamic within patient communities. And then when larger communities, just like Titania said, have sort of, I don't want to say been ignored, but sort of, not that same attention has been paid necessarily, and their population is so large, that also forces you to say, okay, what am I hoping for today? I mean, I think urgency, and I think it plays a role in just the medical treatment of our children too. Like, your child needs a feeding tube, there's a sense of urgency, like, what is that urgency? Can you step back long enough to understand what are you hoping for? What are you expecting? And again, I go back to that's a very different thing. And this is true with research. We have to the way we talk about it really matters. The words that we use when we talk about therapies and when we talk about research and we talk to patients and families really, really, really matters. And in my experience in the medical community is we don't pay enough, doctors don't pay enough attention to that when they're speaking to patients. And they often make it very goal-centric. And because it's goal-centric, parents have a hard time pulling themselves back from that and seeing the full picture. So that's where palliative care can really come in and help you sort of reassess and redefine. But this is especially critical when it comes to trials. What do you, and how we talk about things like, inclusion criteria really matter. Why are they there? Parents need to understand that there's a reason they are going to be hurt by those inclusion criteria. Families, patients are going to be hurt by those somewhere along the path. And then when we talk about trial outcomes, we need to talk real families and say, okay, you're in a low dose clinical trial right now. Do you really understand what that means? You can hope for some changes in your child, but it may mean they're not going to be the most efficacious changes. And let's be honest with that family and say, can you wait and not participate? Maybe they can't. Maybe they can't wait till the third trial. But the language we use when we talk to them about those options and removing the urgency as best we can will help them, I think, keep hope throughout the process. And I think I would expect lead to better outcomes at the other end of a trial, whether it's successful or not successful.
Laura, did you have something you wanted to add?
Well, Jennifer is absolutely right. And I think this dovetails with your comments about autonomy. Autonomy is, in the pediatric world, it's the parents' autonomy. We sometimes see children who may have different feelings about treatment, different feelings about pursuing aggressive care. And it's hard, I think, ethically to find the balance sometimes in those situations. There's just an overlap of gray. It is, I think, one of the most challenging things. Years ago, I knew a little, she was a young 10, 12-year-old who made it very clear she didn't want any more treatment. She was just done. And her parents, of course, felt differently and bribed her, not bribed, but, she wanted a puppy, she got the puppy, all of these things. And, ultimately she died. But it's just, those are the third rail in this work sometimes. And I think, back to Jennifer's point, when parents ask a physician, isn't there anything else we can do? Isn't there anything else we can try? The answer is always, at least in my experience in oncology, yes, there is something. And they grab on that yes like a comet, and they are just going to go with it. But what it's not explained often in a nuanced way, so they really have an understanding of what the disruption may be, what it might be, to live through this. And it's really, really hard. And the conversations around these issues are really, really hard. And, palliative care is where, from my experience, the best talkers in medicine practice, because they make the time. They may not have the time, but they have the skill in having these conversations and explain it in a way that I think is both ethical and hopeful, because you feel like a bad parent if you don't do everything, when the reality is there may be hope and beauty in living with the time you had. We had a teenage boy who wanted to stop treatment. He did. He went to the Super Bowl. He had a fabulous 6 months. Another family who made the same choice for their much younger child, who had a spectacular summer with her brothers, and they were out of the hospital, and the family had a fabulous, terrific time. But lifting up that side doesn't often happen in the world of academic medicine, where you are on the hope train, and people really feel like a bad parent if they say, Well, I don't really know if I would want to do that. And this is where I think the art of medicine and, the complexities of hope sometimes take on different meanings. And one last thought about hope, I think it's inextricably linked to love. Almost every parent early in the diagnosis will say, there's been such an outpouring of support. There's been so much love. I know people know us, but I didn't think they cared about us. And when you listen to these stories over and over, there's just an outpouring of love. And I, will sometimes say, and yes, that's where I think God is. And, I think wherever there's love, there will be hope in some form. It's like the pilot light that keeps hope alive.
Thank you so much, Laura. I want to shift a little bit because it relates to what I think all of you have said in some fashion. But particularly, Laura, what you were just saying about how in academic medicine there's the hope train. I want to leave this as an open question. How is hope used in various corners or among, I would say, stakeholders? How are we using it well, and perhaps how we're not using it so well or misusing it?
Maybe I can quickly just jump in and say, as I said before, personally, I'm very cautious. Obviously, we don't have, on the industry side, we don't have direct or many direct interactions with certainly participants in research, but we do with parents and advocates. And I keep my hope as circumspect as possible, because as you heard other speakers say over the prior 2 days, at least with gene therapies and gene replacements, there's still a lot we don't know. And we do have to monitor participants in those trials for quite a long time. So I'm very cautious about the hope, but also I think it's just very important to back to a bioethical hallmark, in terms of respect for persons, really disclose everything that we do know, and as Laura and Jennifer said, allow parents and families and children themselves, at least in the pediatric context here, to process the information and engage their own hope, and set that accordingly. So just from a perspective of developing gene therapies, that's really all I wanted to say.
I mean, I think the world uses hope sometimes as a marketing tool. I know when I was fundraising, I used the word because it's intrinsic to everybody. Everybody can understand it. So, I wasn't the other because I was accessing your hope. So I wasn't the mom who just had a sick child. I accessed your hope. And I think we do need to be more careful. And again, I go back to, these are the words that we choose then when we talk about certain things, especially around science and scientific advancements and what's coming. And, I once had a disagreement with a doctor who called it patients could now have rational hope that a therapy will come to bear during their lifetime. And that implied that some hope is irrational. And I don't think that is the way we should speak about hope ever. And I would say that we should think more in terms of goals, and we should be really clear about risks and benefits, and we should be confident that patients and parents have the capacity to weigh risks and benefits. And the more we can talk about them in lay terms and you sit down to do that informed consent, it's overwhelming and it outlines all of those things, but it doesn't say what's the emotional risk when we get to this outcome. We don't actually have those discussions, and they should be part of the process along the way. I mean, I'm friends with a family who has a child with Batten's disease, and they participate in an enzyme replacement therapy, but it was made very clear that this was not going to change their child's eyesight issues. And when you listen to that interview on CPN, you will hear that the family understood that expectation because somewhere along their path, someone had a really good conversation, and they talk about the emotions of knowing their child is still going to lose his sight. And so we can't ignore, we can go down the lane of let's just talk about what are the physical benefits. But when we ignore the emotional parts of it, then what we set ourselves up for is this conversation about hope, because we haven't addressed what hope includes. It includes the real things and the emotional things.
I love that you said that, Jennifer. Thank you. I wanted to piggyback on that. We use hope as a slogan. Hope lives here. We sell hope. And not just we, the medical industry, we, like our culture, like our American culture sells it, even to other countries. Come here because we have the best medicine, the best treatments. We have the best hope that you will be cured, you will be fixed. That yes, that Laura said of, can you give me something to treat? And it'll be 5th line, 6th line, 10th line trial therapy. And we use this term hope, and we don't tease it out from love. We don't tease it out from emotions. As Laura and Jennifer said, we use it and we stick it on banners and we sell things with it. But then that hope has to change because it's a fluid hope. And when the persons end up, I end up speaking to them as a palliative care person, as a palliative care doctor, I do have those conversations about emotions and redefining hope and looking at a simple thing as a beautiful hope, looking at your eyes opened, or you're able to sit up, or you're not in pain right now, as hopeful, and redefine, and having friends and family that are involved and love you as hopeful. Because again, needing to readjust what is hope, because we sell it and we're great at it, but we're not great at the other part, when you have to think about hope in a different way.
I can reflect just quickly on, I get a little emotional thinking about this, but one of the most memorable and difficult conversations that I've ever had to have as a professional was when the company that I was working for decided to shut down 2 rare disease programs. And both of them had been in development for quite some time and had, again, proportionally a large number of patients with these conditions on sort of long-term therapy, and many of them believed that the therapy was working. It wasn't a gene therapy, but anyhow, having that conversation with the 2 advocacy groups, one of which had a patient who had the condition, an adult patient. It was just unforgettable. We were taking away, by discontinuing this program, their hope, and there's really nothing I could say to sort of redirect that hope. It was so focused on the present and on the treatment that they were receiving that it just wasn't something that could really be directed toward a future. And I'm sure that Moshe and Tartania, you deal with conversations like that almost on a daily basis. But again, I anchor to those interactions because my hope was that I could, at the very least, convince these patients and these advocacy representatives that their contribution had been really important, despite the company's decision to shut the programs down. And I never want to lose. I've never lost sight of that, and I think it's important to never lose sight that if patients and parents do make the choice to participate in a clinical trial, that the industry, the company, the sponsors, the investigators owe them the best stewardship of the data and the contributions and the efforts that they make to further the research, whether it goes whether it gets applied by another company, the hope is that in aggregate, it will be meaningful.
Thank you for sharing that, Rafael. I especially appreciate hearing that voice from the sort of non-clinical world, because as Jennifer mentioned, I think there's even the perspective sometimes from parents, from families, that perhaps the doctor's taking it away, or then in this case, the company's taking it away. Someone who has control, and that control is somehow cold and calculated. There are reasons other than perhaps the treatment of the patient and the child that are involved. And I very much appreciate hearing that and you sharing it. Before we jump to questions, because they're starting to come in the chat, I wanted to first of all thank each of you in particular, because conversations that I've had in the past 6 months to a year about how healthcare is changing because of the pandemic and sort of coinciding with changes in technology, but then also in regards to the public's perception of what it is that we do in healthcare. And as I was preparing for this, I was thinking, we keep saying the word stakeholders when it comes to, we were thinking about hope, but also other aspects of what we're talking about in ethics and other topics that come up in the research that we're doing. And I kind of want to reframe it for the sake of us here as we're all caregivers to some extent. It's healthcare. We show up to work every single day for one reason, and that's that we care. If we didn't, we wouldn't do this job. We wouldn't have the passions that we do, whether it's whatever the reasons are, but we do it. And that's why we show up. And that, as I think Laura started with, coincides with love and therefore hope. So I thank all of you for caring in the way that you do and contributing that care to furthering this discussion. I want to go to some of the questions that are coming in and some comments. So I want to start with the first one up here. If someone asks, can one or more of the panelists talk about day-to-day involvement of the child or a patient in the discussions of what they are hoping for and what's realistic? And I'll leave that open.
I can comment on that. I don't know if there's an answer for it, but I just remember it's one of those unforgettable moments. And it certainly was for the neuro-oncologist who had to tell a patient who was 13 that there was no more treatment for her. And she was very bright. There was no parent in the room. I happened to be there because I had been visiting her. And she just kept asking him question after question after question. It's, it could be, it could go to your blood. Well, why couldn't I have a blood transfusion? Because it's in your marrow. Well, couldn't you give me a marrow transfusion? And she just was realizing that she was going to die. And it was absolutely heartbreaking, but he had the courage to tell her the truth. And I would say that is a courage born of love. And afterwards, I talked to him about it, and I said I thought he had been really present to her and had done, beautifully in a tough situation. And what he said to me is, he said, I usually have these conversations with parents. We're in a family meeting, we tell the parents, they ask me questions. And even though he was a pediatric oncologist who'd been doing this work for a long time, it was very rare when he had to sit and tell a child that there were no more options. It is hard to do, and I think there's some avoidance about engaging children in these conversations because it's just like, it's searing. It is brutal for everyone, but it's important to do. So important. for the dignity and autonomy of the child. Getting back to ethics.
I want to piggyback on what you said, Laura. I wanted you to talk first. Actually, I was like, talk first, please. So I actually work in the world of adults, really geriatrics. So I'm actually on the other spectrum. But in my world, I deal with a lot of children. So the children of my patients, and I have a lot of children tell me, well, I don't want daddy to know. I don't want mommy to know. And this is how I always address it, because I'm always a patient first. And as a patient, I live in my body every day. And I know, and I say this, that, you know, when you have a cold and you know that you might be feeling a little off, a little different, and you're like, I think I have a cold. And then someone comes along and says, hey, you know, you have a cold. And you're like confirmatory of it. Like, oh yeah, I kind of knew it, because it's your body. You're in it all day. I say the same thing to the children. And I say, you know, mom and dad already are in their body all day. They know things are changing in their bodies. So where you're saying you don't want them to know, when I usually talk to the parent, they're saying, yeah, don't tell my kids. They don't think I know. And everybody is avoiding this conversation. And my colleagues in peds, they kind of tell me the same thing happens in that world too. Oh, don't tell the child because the child is too young or not aware. But the child is in their body and they understand and experience things are not right. When I was I am in my body as a child, I knew things weren't right. I knew my parents weren't trying to tell me everything, and I was pointing it. So when you mentioned that 12-year-old asking very clear questions, that was me. Because you're in your soul, you're in your body, you know things aren't right, and you want clear understanding and answers. So I say to do the same thing that I do with my kids and my geriatric patients in the pediatric world. Be honest, open. I know that's hard. People say, oh, but I'm going to take away hope. But that's fear. And fear festers a lot of other negative things. I think having hope, having love, but also having understanding is key.
I loved that, Tartania. I love that. We have this, we always go back to that movie. I can't remember what the title of it is now, but Jack Nicholson plays a military, it's a military movie, and it's got Tom Cruise in it. He's the lawyer, and Jack Nicholson screams, you know, the reason why he's not telling anybody the facts is because they can't handle it. But the reality is we can. We have the capacity to handle these things. But what we do need is just the truth. And that, I think, is what gets in the way of holding on to hope, even though it may not be what you really ultimately wanted. In other words, you still can keep hope even if the outcome isn't what you had originally thought you might be or expecting to get.
One of the things I certainly see here, and I'm really very fortunate to see this, is that when we're able to have this conversation, and I'm speaking as a clinician rather than a moderator here, but when we're able to have these conversations very openly, when we get down to the fundamentals of what we as human beings need, then our personal, familial, communal hopes then come to rise, so long as we are careful about that language. When we are communicating with language the other can understand, we can then peel away the perspectives that we use sort of as walls, whether it's the perspective of industry or of religion or family or personal expectations, beliefs, pain, anxiety, other things that are going to color it. There are a bunch of questions that have come through that sort of share this theme in common. I want to just pose this. As a parent, how can trial sponsors, and I want to include clinicians and other caregivers, how can they shift their language to better convey what's possible and what's not possible, what's reversible, what's not reversible, what's uncertain and what's certain, especially when something's not proven. It's a trial, it's a phase 1, it's a phase 0. It's not proven. There's so much that's unknown. So you have a family that is hoping for, at most, right, potentially a cure. Certainly at the outset, there's this promise, not the actual verbal promise or contractual promise, but a promise of some outcome. So how can the language change across, I would say, across all of our perspectives?
Yeah, I mean, it comes back to something you and Tartania said earlier, Moshe, both, that in this country, we are a beacon of hope, whether it's in medicine, whether it's in technology, whether it's in our society has this very sort of hopeful, brave kind of culture, and for as beneficial as that is for a lot of reasons, it also has a little bit of a dark side, which is, maybe we don't address more difficult facets of a conversation as directly as we should. To the question, I agree, that's an area of enormous improvement in terms of disclosure and consent. And personally, I think the consent process needs to be, in thinking about the future of research, clinical research, it needs to be overhauled. It's too complicated. Not to sell short what patients and parents need to know. On the contrary, it's giving them information that's clear and actionable, not a 30-page document that reads like a legal contract. We've talked in PGTME about some ideas that some institutions are implementing that could really help with that process, but unquestionably, frank conversations about what's to be expected, what's known and what's unknown, what we're guessing about, what we're hoping about. All these things need to be improved. Absolutely.
Yeah, I would piggyback on that to say the more opportunities we can give patients and families to understand not just what, the great things that might come out of this, but also understand the learnings of the past. So maybe, there was another trial you could point to say, this is what they expected, this is what came out of it, this is the reality. Let's really just I think lay it on the table, and then also don't forget to talk about the emotional part of it. Like, don't just focus on the logistics and the intellectual parts of it. You have to then, because what it will give a family is a better way to hold on to it. It will give that family a place to hold on to it. So using language that helps the family attach it to not just their intellect, but their emotion will help for them to be able to process it better, so that what you get at the end, when you have that family and you have to tell them that, the trial got stopped, that it isn't that you're taking away their hope, that it's just that singular possibility went away. And if we can talk about it that way at the beginning, we have less failure at the other end. I will tell this, and it's not related to clinical trials, but I think one of the most powerful moments in my life, my son died very unexpectedly. I mean, obviously he had a genetic disorder and we expected him to die, but the circumstance under which it happened was a very truncated, short 24-hour period, and it was very stressful. And I think the most impactful moment to me was when my palliative care physician stood next to me, and I said to her, hey, wait a minute, we had a plan for this and we're totally off script right now. This is not what we talked about what end of life was going to look like. And she was able to say to me, I'm scared too. And these are the things I don't know either. And her saying that to me freed me to feel less responsible for the negative outcome. It freed me to understand that it's okay to be vulnerable and still come out with hope. And I think we miss that boat a little bit around research sometimes. We don't always address that.
It's so true, Jennifer. I hear from parents want that emotional connection. It's not that they want the provider to say, I'm not giving up on her, there's still hope. the integrity, the honesty, and the decency of saying, I'm scared too, I don't know, it sounds paradoxical to say a blessing, but she's saying, I'm standing here with you, we're standing in vulnerability, but I'm not abandoning you with a false promise of a hope that I doubt will, that it exists anymore. And I think, it's hard for the way doctors are trained and how they are in the world to admit that vulnerability, but it means so much to the families. It means so much when a family will say, and the doctor had tears in his eyes. I think he really cared. Of course they care, but it's that honesty and expressing the vulnerability that's such a challenge.
I'm just going to reflect here for a moment about something that we talk about in palliative care, where we sometimes will ask, always will ask families about what they're hoping for. We ask parents, what are you hoping for with your child? Sounds like a silly question, but as we've discussed a lot today, those hopes are fluid. It could be for a good 6 months. It could be for a good death. It could be for sitting cross-legged on the floor. I'm going to make a bit of a plug in reverse, perhaps not the responsibility from the patients or families, but for us in healthcare to ask of ourselves, what are we hoping for? Because I'm thinking about that now, just hearing what you, Laura and Jennifer are saying. What are we hoping for? And that we perhaps need to keep that conscious in our minds to manage our own expectations as well, being to some extent in the driver's seat. There's another question that came in that it'd be great to hear from you. Does the uncertainty inherent to what we know about gene therapy drive false hope? And does that leave people to fill in the blanks with something they're hoping for that is not necessarily reasonable?
Anybody see the New York Times story on Sunday?
Mm-hmm.
Yeah, I mean, it's a big responsibility to be involved in programs like this that we don't know how long they'll last. We don't know how successful they'll be. We don't know if ultimately we'll be doing harm. It's a huge responsibility, like with any new frontier. I think we have reasons to be optimistic, and there are, as Jennifer points out, there are both success stories and failure stories, but we have to be really responsible about collecting and communicating that information. As Jennifer said, and as you said, Moshe, I'm just thinking through how can we get, being very practical here, get IRBs to think about putting not that informed consents need one more paragraph, but to craft part of the document or craft into the process this emotional component that to be discussed with parents and pediatrics. It's a really important thing that I'm trying to get my head around how we might tackle. And I'm getting a question here. There was a story on Sunday or Saturday in the New York Times written by Gina Colada about a first-in-human adult participant with type 1 diabetes in a gene therapy trial who has shown signs, at least, of early signs of a cure, and that's incredibly exciting. And so that represents one pole of this question that's being asked. But another, as Jennifer I think very wisely points out, is we need to also learn from the programs that have not been successful and communicate those, take the learnings from them, but communicate those very openly.
I want to throw out a comment, perhaps for more of an open comment to those people who are in the business of science communication, that those of us who are sort of doing science and doing healthcare in situations like this, whether it's the diabetes situation or certainly in gene therapy, which is what we're talking about, that, as Jennifer's saying, the words that we use are so important, not only in the moments of stress, in the moments of real vulnerability, but in general, when an article is published. And even Crispr itself, I remember distinctly, and I still have this in my brain, I'm more knowledgeable than most, than the average layperson. about CRISPR, for example, being, oh, it's like Microsoft Word, right? That it's that easy. And the idea that it could be that easy is so misleading, including to ourselves, if we convince ourselves that that's really what it is. So just as a plug for any of us doing science communication, to be that careful, because then we really run into that issue. And there's a question here that came in that vein, right? Is it ethical to say that gene therapy is a cure? And if it does that give false hope for an outcome that is entirely uncertain?
I actually want to comment on the term false hope. We've said hope is fluid. So you to say that my hope is false is to make an assumption of knowing what my hope is. My hope might not be what your hope is. I think clarification on the term hope is important. So yes, if you come and tell me you have false hope, on what? My hope is to not be in pain today, not that I'm going to have a cure. So your hope is that I'm going to have a cure, and you're having false hope of I'm not having a cure. My pain is just relieved. But I'm not that. So I say, in this vein of making hope fluid and defining it as fluid, redefining these terms that we have ingrained in science and that we kind of throw out, but when you actually get to it, you're like, it's not so easy to just throw that out and know what everyone else means. I think a big issue of what occurs with like selling something like it's a cure, it's we need to be cautious. I do think we need to like make an ethical decision, like have a true conversation on this terminology. I worry about it because being both the patient and the doctor receiving information about having a cure, like the patient in me jumps for joy and says, yay, but the doctor in me says that ain't realistic. Let's pump the brakes. So that's not realistic in my time frame right now. So I think we need to yes, we definitely need to redefine things, ask what does hope mean in each person, and not just assume your hope is false versus my hope is real, because that's the other side. And my real hope and your false hope is it's what is your definition of hope? And then yes, let us redefine. And I do think it is ethical to not just throw these words out like cure, because what does that mean? To who? What are we curing? Who are we curing? How are we curing it? And what time frame are we curing it? None of those things are really talked about or said, but we just like to throw that word hope out or cure out.
I wish we need to like take that as a clip, and that needs to be broadcasted. Just that right there, the who, what, where, when, and why.
Yeah, I would not say, I mean, I would shy away from the word cure. I mean, I'm not a scientist, and there may be a gene therapy out there right now that is a cure, but do we really know? Because there's enough time gone by that patient might not get some other some other problem from their disorder that they had in the first place that we just haven't seen yet. So I mean, that's another one of those words. So the goal of gene therapy, right, is for you to have less of the symptoms of your disease, right? So again, it goes back to what are the words we're using? Like, what are our goals? What are our expectations? And using those words to temper urgency, is I think what is ethical, and cure doesn't necessarily temper urgency.
Yeah, I'm going to throw my pitch out to Rafael. I think I may have said this in one of our very early meetings of PGTME about that very thing. I think that I thought maybe gene therapy is a bad term, right? The idea of therapy implies that when it is given, it is going to be therapeutic. And so much of what is going on is still being tested. If it's still of uncertain or unproven benefit, there's an interesting ethical question about whether the use of the word therapy, at least in my mind, is appropriate. But I'm just going to leave that. I'm going to leave that out there.
Yeah, no, it's a very, there's a lot of tension, and clearly, as everyone has said in several different ways, room for improvement in communication, maybe a lot of room for improvement in communication and expectations, and including elements like the emotional element that Jennifer's pointed out and Laura's pointed out. Agree. I mean, nomenclature matters, and in this in our society, again, this is something that I try to bear in mind, is that there is this constant, at least here, I lived in San Francisco for a long time, so the tech culture there is just so it just reverberates, or used to. No problem was unsolvable. No technical problem is unsolvable. Just get a bunch of programmers in a room and design the code, and it will change everything, and there will be a disruptive technology. And so a lot of that spirit has been transformed or translated into biotech as well. There's reason for hope, but we're not, cures a word I never use, and it's you can't know. You can't warp. I wish we could warp time. This is why I say that all the time. I wish we could warp time and be in the future and know how long these things last, whether bad things happen, whether good things are sustained, the impacts of on every level in patients and caregivers' lives. But it's just it's one of the big challenges, is being patient.
Thank you, Rafael. We have a few minutes left, and I thought it might be appropriate, both given the title of our session, the topic, and I think seasonally, last week, perhaps some of us had gone around the table and our matriarchs or leaders of our families might have said something along the lines of nobody's eating until everyone says what they're thankful for. We shouted my mom down from that one. But I thought it might be important to hear from each of you after this conversation, as you think about this going forward, and what we're doing with gene therapy, and in particular how we think about gene therapy, what you are hopeful for.
What I'm hopeful for is really linked to something you said earlier, Moshe, about how we all show up. And all of us know we're living through bitter, polarized, hateful times, unlike any I've known in my lifetime. And then I come to work at this hospital every day. It's a 500-bed hospital with people from all races, class, religion. It's just a big bouillabaisse of the human condition. And it's united by people who all have the same mission, to make lives better for children. And I think that's, my hope is that we can do this if we do it together. And that the things that unite us are greater than the things that divide us. When those cells come in for a transplant, you don't care who they came from, you're just giving thanks that there's hope. And I think that as long as we keep working together, gene therapy, whatever it is, we can get there.
Thank you, Laura. Rafael?
I think that what I hope is that we can, incremental change is not sexy, but it's important. And as a more youthful person, I believed in sort of major change or magnanimous types of change, and I've come to embrace incremental change a bit more in my older or middle age, let's say. So my hope is to really implement some of these changes, like getting greater cooperation between industry, amongst themselves, and regulators with us, and patient advocates with all of us, so people can share information. Companies are willing to share information. Regulators are willing to share information. So the whole process can move forward more efficiently, so that patients, the patients who really need potential therapies, can get them more quickly. That's what I hope.
Thank you, Rafael. Jennifer?
I mean, I love that, Rafael, because I do think the cooperation and the sharing is really what I would hope for gene therapy. But I thought I'd just share a story I heard this morning at our Courageous Parents Network team meeting, and sort of ties back to faith a little bit and hope. But it was imparted to me that the grandparent of one of the families we are in contact with at Courageous Parents Network was an Auschwitz survivor, and he said he doesn't really like the term hope anymore, and instead he thinks about hope as a maybe. And what I really want is for us to begin to think about gene therapy as an opportunity for that maybe. It may be this, and it may be that, and it may not be this thing. And again, and I would encourage the sharing too that Rafael spoke to, so those maybes become a greater opportunity. But if we can think about gene therapy as a maybe opportunity for our patients, and bring that perspective as we go forward with it, I think we're going to find that the opportunity for hope stays more present.
Thank you so much, Jennifer. Tartania?
Last but not least,
Certainly not least.
I want to piggyback on what Jennifer said, because she kind of was, that's what I was thinking. I hope we readjust the word hope. I hope we readjust and redefine a lot of what we say in medicine, or a lot of what we do in medicine, to incorporate the emotional side to it. I wish everybody had a little bit of palliative care-ness in them, from the doctors to industry to everywhere that deals in the medical world, that to families and patients, that we not only look at the clinical medicine science, but we look at the emotions and we make a totality, because that's what we are. We're a total package. We're a hot total package. And we need to look at it in whole and not just tease things out and not make assumptions.
Thank you, Tartania. Thank you, Rafael, Jennifer, and Laura. We are out of time, and I want to thank all of you for the discussion, all the attendees for the comments, the questions. They were really helpful in spurring the discussion. And I hope all of you have a great rest of the week. Be sure to tune in tomorrow's panel. And if you're not registered, it's not too late to do so. And on behalf of PGTME, thank all of the attendees, the participants, and those behind the screens who helped put the event together. And have a great rest of your day, everyone. Bye-bye.
Bye-bye.